Good morning, everyone, and thank you for joining us bright and early. It's a pleasure to be with all of you today. My name is Dr. Sterling McPherson. I'm a professor and I'm the Vice Dean for Research in the Elson S. Floyd College of Medicine. I appreciate everyone who's able to be here today. For those of you who may be new to this series, we launched this virtual research forum in about 2021 to share and highlight our work with community members. Our aim is to give you some meaningful insight into the research taking place, not only here in Spokane, but across the state and across the country and beyond. So today we're especially pleased to feature our collaborative research with one of the nation's top 5 pediatric research institutions, the Seattle Children's Research Institute. This is an organization dedicated to advancing hope, care, and cures for children and families. At WSU, our researchers are making significant contributions across a wide range of disciplines, from sleep and performance to addiction sciences and cancer, chronic disease, autism, nutrition and exercise physiology, and neurological disorders. The breadth of our work is truly extensive and focused on addressing several complex real-world challenges that have profound impacts on how people feel, function, and survive. Before we introduce today's speakers, I'd like to begin by sharing a land acknowledgement in honor of America's First Peoples. Washington State University acknowledges that its locations statewide are in the homelands of Native peoples who have lived in this region from time immemorial. The university expresses its deepest respect for and gratitude towards these original and current caretakers of the region. As an academic community, we acknowledge our responsibility to establish and maintain relationships with these tribes and Native peoples in support of tribal sovereignty and the inclusion of their voices in teaching, research, and programming. I also wanted to touch on who we are and how we at WSU serve the state of Washington. Washington State University is a land-grant university, and the way we serve our state is through education of the state's future workforce, service to communities and organizations that serve our needs, and research that works to improve the health, quality of life, and well-being of every resident in the state of Washington. WSU research is being done across the state of Washington and beyond, as I mentioned before. And if you're looking at this slide, it's primarily focused on the health sciences. You can see our clinical sites and partnerships across the state in both rural and urban settings. So shifting gears a bit, we're fortunate to have a remarkable group of researchers with us today who are ready to share their work as we hear about the latest science under the theme of bridging gaps in pediatric health from neurodevelopment to immune response. A quick reminder before we get started, you're welcome to submit questions at any time using the Q&A feature on your screen. We'll monitor them throughout the session and we'll address as many as possible after our speakers finish their presentation. We are going to start with Dr. Eka Berduli, who is an associate professor in WSU's Elson S. Floyd College of Medicine, and Dr. Brent Collette. He's a principal investigator with Seattle Children's Research Institute Center for Child Health, Behavior, and Development, and he's also an associate professor at the University of Washington School of Medicine in Pediatrics and Development Medicine.
Thank you, Sterling. It's such a pleasure to be here with all of you.
And thank you very much. I really appreciate the chance to talk about our work. I will start sharing our slides. Just make sure that's showing up for everybody okay. Yeah, good. Okay, we are going to be talking about disparities in neurodevelopmental follow-up of high-risk infants in rural communities. The scope of the problem is fairly big. So about 10% of babies are in the NICU at birth for things like preterm birth, low birth weight, and complications related to prenatal exposures or different problems that can happen. There are disparities in terms of who ends up in the NICU. So for example, rates of preterm birth are higher among Black, American Indian, Latino, rural, and lower income newborns. These high-risk infants have a greater risk of neurodevelopmental impairment that can be attenuated actually with early detection and interventions that can start really very early in infancy. As a result, there's a lot of interest in monitoring these babies over time to make sure that their development is progressing as expected and to get them support that they might need. Neurodevelopmental follow-up involves multidisciplinary assessments. So often there might be physical therapy, occupational therapy, speech-language pathology, neonatology, psychology, lots of different players in the mix, tracking development, often doing standardized measures at specific ages to sort of track how kids are developing. It's recommended that babies get, high-risk infants get follow-up starting within the first year and usually going through at least 36 months, and some centers actually follow for quite a bit longer than that. Those disparities in follow-up persist. So about 50% of the families who might benefit from neurodevelopmental follow-up actually receive it. And there are a couple of different ways that this can go awry. So we know, for example, that Black and Hispanic or Latino families are less likely to be referred for follow-up to begin with. So they might not get that initial recommendation to follow up with providers. And then among those who are referred, those who are lost to follow-up are disproportionately rural, have limited financial means, or speak a language other than English. In Washington State, some of those barriers, including things like distance, have been documented, but solutions are scarce and not all that consistently implemented. This map shows counties with the highest rates of preterm birth. So those counties that are shaded in sort of a peach orangish kind of color have the highest rates of preterm birth. The level 4 NICUs are shown in yellow, those little yellow stars, and the level 3 NICUs are shown in blue. Those NICUs are often where the expertise resides for neurodevelopmental follow-up. So they would have the expertise in neonatology and some of the other disciplines that I mentioned. And as you can see, they're not necessarily where the greatest need is. In fact, they're clearly not where the greatest need is. The NICUs are kind of lined up along I-5 there at the west end of the state. There are some other NICUs around Yakima, Tri-Cities, and Spokane, but in general, the places where rates of preterm birth are highest are quite a ways away from those centers, and that does pose this burden for families because they're likely either traveling to one of these places or they're getting community referrals that can fall through in lots of different ways. And we know that this distance is kind of one of the primary things that families report keeps them from getting follow-up.
I'll continue now. So another factor that puts infants at risk for developmental delays is neonatal abstinence syndrome. So neonatal abstinence syndrome refers to babies that were exposed to opioids and other substances before birth may develop a myriad of signs and symptoms of withdrawal. And as you can see from this figure, the rates of neonatal abstinence syndrome are much higher in Eastern Washington, which includes rural counties close to Spokane, and specifically Spokane County. So these higher rates of neonatal abstinence syndrome means that possibly more infants are at risk for neurodevelopmental delays. But as Brent mentioned, follow-up care often isn't consistent or accessible to many families, especially those residing in our part of the state. So we can see that the chart shows how much higher Spokane County's rates are compared to both the rest of the state's average as well as national averages. Next slide, please. So we partnered with Seattle Children's Research Institute to study what helps or hinders families from accessing neurodevelopmental follow-up. We have two goals for this study. The first goal is to identify barriers and supports that affect whether families attend those follow-up appointments. And the second goal is to test which possible solutions may be realistic and acceptable to families and providers that provide these services. The approach we are using is surveys, first to learn what gets in the way of families attending appointments, and then to test possible solutions that might work for those families. Next slide, please. To accomplish these goals, we did a few things so far. We've built a strong interdisciplinary team across Washington State University, Seattle Children's Research Institute, and University of Washington, as well as, importantly, local partners in both Spokane area and Yakima. To date, we've completed baseline surveys, so those first goal surveys with a range of different professionals. Those include neonatal intensive care unit staff and providers, early intervention providers, and pediatricians. So these are all practitioners who work directly with these families that are at risk for not following up. So the next step would be that we'll use their feedback to co-design and test practical solutions. At this moment, we are doing the important work of collecting these surveys with families. So these are actual families that either did end up following up and attending appointments or never followed up and didn't attend appointments to try to figure out what are those barriers and supports that they've experienced. So next slide, please. So these are the initial or preliminary survey results. These only include the providers so far that we've surveyed, not families to date. But so far, what we are seeing from the preliminary results is that from the providers' perspectives, families seem to face multiple overlapping challenges when it comes to attending follow-up appointments for their children. So many seem to feel overwhelmed and struggle to manage multiple appointments required for follow-up. The logistical barriers such as navigating work schedules for the parents and lack of transportation seem to be major obstacles, as well as cost and distance to the appointments, and no or limited childcare for the infant's siblings. All those make attending appointments even harder. So it seems that from these preliminary results, they highlight why support systems need to be flexible and family-centered to allow families to maximize attendance. Next slide, please. We also surveyed these practitioners about what could be a possible support. So what are those factors that make attending those appointments for families easier? So what are those factors that promote attendance? And it seems from these preliminary results that families are much more likely to attend follow-ups when services are offered in their preferred language, with reminders and clear information about the benefits of attending developmental follow-up. Specifically, recommendations by their pediatricians seem to really be important to grow trust. And then also support with those logistical issues of transportation, flexible scheduling of appointments, and ideally being located close to home or a shorter distance. So it seems that accessible, personal, and easy to navigate systems might make a big difference. And next slide, and back to you, Brent.
Thanks, Eka. So in terms of our next steps, as Eka has mentioned, we're working really hard to get families involved. One of the challenges with this kind of study is the families who you most want to talk to are sometimes the least likely to participate in research. So as you can imagine, if families are not participating in those follow-up visits, they might also be hard for us to engage in a research study and to get their responses, even though we desperately want that. Those are the folks who we would most want to talk with, because we really do want to hear their input and develop solutions that are responsive to their needs. So we're working hard to do that in partnership with a couple of different community agencies. We are also planning to develop that solutions survey. So once we get these data, we will sort of summarize themes and then generate potential solutions and go back to those same respondents and say, okay, here's what you told us with your concerns. Here's what the things that were listed as barriers and promoters. What do you think about these solutions? How feasible do you think these are? How well do you think they would work? This kind of a thing. So that's our next step. We're starting to generate that based on the initial provider feedback that we have, but of course, family voices will be really, really important to that. And then a next step is to take those proposed solutions and to test them. So we really want to develop different interventions or alternative approaches for follow-up that might be responsive and might help to improve that follow-up rate. In addition to acknowledging the funding from WSU and Seattle Children's, we need to acknowledge several different people that are involved. So Greg Valentine and Sarah Netchis are both neonatologists here at Seattle Children's Hospital and the University of Washington, and their input has really been critical for us. Cindy Trevino is a psychology colleague of mine who's been really helpful in thinking about this work. And then Arushi Vyas is our coordinator for the study, really doing a lot of the work on the grounds to get the surveys delivered to the right people and things like this. Whaley Yuan is helping with implementation and analysis, and Anna Charles is a student volunteer who's been helping with some of the work that we do when we're locating where the providers are and where the level 4 NICUs and things like that are located. She's been helping with that. And then community partners around Spokane, including Joya, Youthful Horizons, Center for Pediatric Therapy, Providence Sacred Heart, and Multicare have all been really, really important and generous with their time. Thank you.
Great. Thanks for that, Eka and Brent. It's outstanding presentation. It's great to hear about your remarkable research. It's really good to see how it's impacting people's lives in Washington. So thank you for that. Moving right along, we are now going to hear from Dr. Erica Crespi, who is a professor in the School of Molecular Biosciences and director of the Hudson Biological Reserve at Washington State University. And she'll be joined by Dr. Jason Debley, who's a professor of pediatrics, pulmonary and sleep medicine at the University of Washington. And he's also the director with the Center of Respiratory Biology and Therapeutics at Seattle Children's Research Institute. They're going to be giving us an introduction to their research. So with that, I'll turn it over to Dr. Crespi and Dr. Debley.
Thank you. Hi, everyone. Thank you for inviting us to share the work that we have done in this collaboration between WSU and SCRI, which really illustrates the translation between basic research and biomedical research. We are investigating how leptin, a hormone that's related to obesity, impacts childhood asthma. Jason and I are the senior PIs on this study that we'll be presenting today by mainly our junior members of our groups who have been leading a lot of the work on this project. First up is Courtney Whitfield. She's a senior PhD candidate in my lab who will be defending her dissertation in May. She has been studying the role of leptin in the secretion of mucus in the embryonic skin of a frog called Xenopus, illustrated by my mug. Here, that is a frog, and it's also a model for the airway development and function of airways in humans. Jason?
Thanks, Erica. So paired with Courtney on this project has been a junior faculty member in my lab, Dr. Weston Powell. So Courtney and Weston had posters right next to each other last September at the first WSU SCRI symposium, which sparked this fantastic research collaboration. So take it away, Courtney and Weston.
Yeah, thank you for the introduction. We're excited to share this. So the Airway epithelium is a specialized tissue layer that lines the respiratory tract that helps maintain respiratory function in part by providing protection from the environment, such as protection from pathogens. But dysfunction in the airway epithelium plays a central role in asthma. And so at SCRI, the Debley Lab investigates remodeling of the airway epithelium in childhood asthma and epithelial responses to viruses. And so using airway epithelial cell cultures from donors with childhood asthma, the Debley Lab seeks to better understand the relationships between, if you want to do the next animation, thank you, between epithelial function, viral infection, and clinical risk factors for severe or difficult to control asthma. And one clinical risk factor that could be contributing to these relationships is obesity. And so at the Crespi Lab at WSU, we're interested in the obesity-related hormone leptin and its many roles during development by using the frog as a model organism. And so leptin's roles in nutrition within adulthood and mammals are well established. And leptin is elevated in concentration with obesity, making leptin an interesting candidate to explore as a mechanism of obesity-related physiology. Leptin is also important for immune function, also acts as a developmental and growth factor, and these functions may overlap. And there's also growing evidence that leptin regulates epithelial homeostasis, which is what my dissertation has focused on. So using scanning electron microscopy, I've shown that an upregulation of leptin signaling by treating frogs with leptin causes an increase in mucus secretion and changes in mucus secreting cell proportions in the embryonic frog skin, which is also a type of epithelium. And so the arrow here points to mucus being actively secreted from the surface of a mucus secreting cell. So the epithelium of the embryonic frog skin functions similarly to the human airway epithelium. Both have mucus cells that produce mucus to provide a barrier of protection from the environment, and both have ciliated cells that possess long hair-like projections that actually move that mucus and any harmful substances that the mucus has trapped off of the airway or away from the frog embryo. And these epithelial cell functions involving mucus are critical to maintaining health of the airway or embryo. And so with the focus of asthma and epithelial function at SCRI and knowledge of leptin as a cellular mechanism mediating epithelial function and development at WSU, we realized the potential for collaboration to merge knowledge from these two models when Weston's poster and my poster were neighboring each other at the joint WSU SCRI symposium last September. And so this became an opportunity to test in the human model what we were observing in the frog embryo. So we set out to test the hypothesis that leptin stimulation of airway epithelial cell cultures causes mucus cell hyperplasia and enhanced expression of viral response pathways. And so to do this, we took 10 donor lines and then treated with or without leptin for 7 days, then infected cells with rhinovirus 16, which is a virus that's clinically relevant to asthma as it's the most common viral trigger for asthma exacerbations. We then processed samples for scanning electron microscopy to look at the epithelial landscape, and additionally for bulk RNA sequencing to look at cellular gene expression changes. So scanning electron microscopy imaging that surface of the airway epithelium showed a thick carpet of cilia in those control cells. Again, the cilia are those hair-like structures coating the epithelial layer that help move mucus off of the airway. Airway cells that were treated with either the low dose at 1 nanogram or high dose of 100 nanograms of leptin showed a reduction in the amount of cilia present. Next. Thank you. And then airway cells that were infected with rhinovirus also displayed differences in morphology relative to the uninfected control. And again, we found leptin treatment continued to reduce cilia coverage in these infected cells. And so this suggests that leptin could be affecting epithelial function by reducing how many cilia are there to move the mucus around and get rid of pathogens, or by increasing how many non-ciliated mucus cells are present.
And so since we were seeing these changes in the ciliated cell landscape, as Courtney showed by SEM, we were interested to see, does this change how rhinovirus is able to infect these airway epithelial cells? Rhinovirus is the most common trigger for asthma exacerbations. And so we were interested in finding out whether or not the virus could infect these cells more easily or replicate more easily as the ciliated cells are the cells that are infected by rhinovirus. We first looked at viral load quantified here in this graph and looking at viral copy number in the different epithelial cultures, either in the control in black. In blue, those had been treated at leptin 1 nanogram or at the high dose leptin 100 nanograms, which is equivalent to what you find in humans with obesity. We did not see any difference in rhinovirus 16 copy number across these three conditions. We also initially set out to look using qPCR at different viral response genes to see if, while there may be the same amount of virus, could there be a different response to that virus? And we did not see any differences. So that let us conclude for now that leptin stimulation of the airway epithelium did not seem to change viral infection of the epithelium or those initial viral responses by the airway epithelium. But since we were seeing these differences, we then wanted to know what's changing at a cellular level in these epithelial cells. Could we detect differences by gene expression? And this analysis is still ongoing, but we took the cells and did bulk RNA sequencing, which looks at gene expression across all the genes in the genome to look more broadly at what was happening. And so while we're still digging through this data and trying to understand the nuances and details, two interesting features started to come out. When we looked at what some of these genes were, we could cluster them into two groups. One cluster of genes were genes related to protein translation and cellular metabolism. And here graphed showing in the untreated on the left, and then the next bar, those that have been treated with leptin at 100 nanograms, we could see a reduction in the gene expression of protein translation and cellular metabolism genes. Interestingly, in the infected state, infection reduces expression of those genes, but when those cells had been treated with leptin, you didn't see that same reduction, suggesting an inverse to what was happening in the setting of infection. We could also see a difference in a set of genes related to cell adhesion and differentiation, where here is the expression in the control cells, and then we see an increase in expression when those cells have been treated with leptin, indicating we think that what's happening is these cells are starting to differentiate in an abnormal way, maybe getting a signal too early or at the wrong time, where they're starting to differentiate or not differentiate as fully into those mature, nice, long ciliated cells. And we think this relates back to the SEM changes that Courtney showed earlier, where we see that landscape along the surface epithelium is changing. We think these gene expression changes could be related to that. So for now, we can start to make some preliminary conclusions. And first, we can see that increased leptin signaling in the airway epithelium remodels the surface of the epithelial cells, both in the frog, as Courtney had shown prior to this work, and now we've been able to link that to what's happening in the human airway epithelium, highlighting how some of these basic work happening in the Xenopus model, we can now link to what's happening in human airway epithelial cells and start to connect to a disease like asthma. We can also conclude that increased leptin signaling does not change viral replication or responses, but we start to see changes in epithelial metabolism, cellular metabolism at the gene expression level, and protein translation, as well as differences in cell adhesion and differentiation. So going back to that triangle model that Courtney introduced earlier, we can start to think about how these factors may influence asthma. So we think of obesity and the leptin hormone related to obesity may not change viral infections, so these areas stay small, but we can start to have a thicker area connecting obesity via the hormone leptin to airway remodeling and changing that surface layer of ciliated cells. We have a lot of ongoing future work to really dig deeper into these RNA-seq data to understand how these gene expression differences relate to that epithelial surface measurements. And ultimately, the goal is, because we use primary cells from patients, is we can link these back to what's happening in these patients, to their asthma severity, their measures of obesity. And can we really understand what's happening at the epithelial layer, how they're responding to epithelium, and link that back to what's happening in the human. So with that, I have to say thank you to a number. We have to say thank you to a number of different people within the different labs, both here at SCRI, the lab staff who's been instrumental in growing these cells, collecting these cells, and helping with the analysis along the way, both here at SCRI and then at WSU in the Microscopy and Image Center. And we'll say thank you and take any questions.
Great. Thanks so much for those presentations, Courtney and Weston. It's great to hear about your research. Sincerely appreciate everything you've shared with us. So we're now going to get into our Q&A session, and we have several questions actually teed up that have come in during the presentations. And as they come in, I'll try to track them as close as I can to make sure everyone's questions get asked. And just to note that there is time. We only had 2 presentations today, so we have time for several questions if folks are deciding whether or not to put those in the chat. So the first question is for Eka or Brent, and the question is, it's great to see such strong collaboration between WSU and SCRI. I totally agree. How do you envision sustaining these partnerships beyond the pilot phase to create longer-term impact?
Thanks, Sterling. It's a great question. I can take that. So sustainability, I think, is very important, and it's been a key focus for us from the start. I think what's been exciting about this work for us is that it doesn't seem to be just a one-time project, but really it developed into a foundation for an ongoing partnership between Washington State University, Seattle Children's, and as well as, importantly, with local clinical and early intervention partners in this area. So, for example, we've already built on these relationships through a new project that we partnered on between WSU and Seattle Children's and University of Washington to develop a remote parent-child intervention to support daily routines like teeth brushing. And this is something we're partnering on, as well as with the early intervention partners that we've already made through the existing project. So that's just one example of how we're trying to expand together into an applied and family-centered interventions that we hope to deliver to more families in this area.
Great, thanks for that, Eka. And I guess before moving on to the next question, it's just a quick comment. It kind of dovetails with the previous question. I think hearing from early stage investigators like Courtney and Weston is actually one really good way to build sustainability into a collaboration. I just wanted to call that out, that it's really exciting to hear from Courtney and Weston who are earlier stage investigators. And I think a lot of times collaborations can thrive when you have people who are earlier in their career start to collaborate. It can build some great longevity. So with that, next question for Courtney and Weston. What were some insights from the frog system that you were able to integrate to the human system?
Yeah, so the main insight that we brought from frogs was that evidence that leptin could be shaping or could be remodeling the epithelium during sustained elevated concentrations of leptin. So we mentioned earlier that obesity and generally respiratory health are linked. So that hypothesis of leptin as a mediator has been around. Mm-hmm. But current studies focus on these like acute and immediate effects, and there's lacking information on more of these chronic effects that would happen in obesity, which was part of the motivation behind my experimental design in frogs. And so we knew that our findings could be applied to human research because there are so many retained features across the frog epithelium and the airway epithelium. But also work in our lab has shown that specifically leptin has similar roles in amphibians as it does in other vertebrates or other systems like mammalian models. So like other roles of leptin that is shared is like wound healing that we've shown, blood vessel development, as well as immune system regulation. So we figured this could definitely be applied. And then I also wanted to say that the other insight that I was really excited to bring a little bit more into the human research side was the scanning electron microscopy, or the SEM. I spent a ton of time early on in my graduate school career optimizing methods for SEM for frog embryos, and I was able to directly apply that protocol to these human airway cells, which was really exciting and that it worked so beautifully. And then, this was kind of the first time that we were able to see this level of detail in this context of leptin and airway epithelial cells, because even though SEM is more of like a classical approach, it's like one of the best ways to get that structural detail. And then to see it in such a fantastic model that the SCRI labs have optimized, and then pairing that with more modern methods has really been informative and gives us a lot to work with. So.
Great. Thanks for that, Courtney. Excuse me. So going back to the next question, going back to Eka and Brent, the question is, why is neurodevelopmental follow-up so important for these babies? And are there certain ages when follow-up is most critical?
Yeah, that's a good question. So it's especially important because early intervention results in better outcomes. So the quicker we can identify a problem in some developmental area, the quicker we can get babies set up with intervention, and the better their longer term outcomes are going to be. In terms of the optimal age, I suppose that depends a bit on the domain. So some babies who are followed might be at higher risk for visual or hearing impairment, for example. And those are things that you can identify in the first few months of life. So there might be very early measures that people would do. Other outcomes, might differ. Some things might develop later. So, for example, language, we know, starts to peak around 24 months, somewhere in there. So certainly there would be some precursors that you could assess, but the language assessments will get more sophisticated as the kids get older.
Great. Okay. Thanks, Brent. Just a quick reminder, if you have a question, feel free to just pop it in the chat, and we'll make sure it gets to our panelists. Okay, so next question is for Courtney or Weston. How might your work lead to future therapies and treatments for asthma?
I think I'll take that one. I think it's collaborations like this that really highlight the need to do research kind of across the whole spectrum, from understanding the developmental biology in a Xenopus model, where you can really dig through and tease out some of those differences, and then taking that to a human model where we can start to ask what's happening in the human. And a lot of what we do is then link it back to how does this relate at an individual level to patients using these primary cells, where we can link and say, why does one patient with obesity, for example, develop asthma and have more difficult to control asthma, but another patient who may have obesity doesn't? Can we start to see those individual differences in how they respond to something like leptin? Ultimately, that's going to be the foundation for how we move this to a future therapy and treatment, where we know asthma is a broad disorder with many different subtypes and different manifestations, similar to people with obesity, where there can be many different manifestations. That interplay starts to get really interesting, and teasing that apart gets really important. Ultimately, by understanding how something, a hormone like leptin, might be changing that epithelial landscape, we start to see, okay, maybe it's not changing how they respond to viruses or these viral infections. We won't focus our therapies and energies there. But if it's changing how they're moving mucus and getting mucus out that airway, maybe we can start to think about therapies and how we might design therapies to really help get mucus out, thin that mucus out. And since mucus production can be such a key feature for asthma, where you get mucus plugs and airways that then can't move air through them, if we're able to augment that, knowing that that's the underlying foundation, if leptin's really driving this, there's a long way to go till we get there, but it starts to get fun to dream about that and think about that, that if we can understand that biology, now we can start to be more targeted and targeted in the right individual as well.
Great. Thanks for that. Sorry, I just want to make sure I'm tracking the questions. I think we have time. So, because we do have one question, but just as a follow-up question to what Weston just said, another question came in. If leptin is changing the cellular landscape of airway cells in culture, is there any way to know if that is happening in people?
That's a great question. And one of the things that really is part of our future work is to try and not only do this in the ex vivo model to where we can grow them in a dish and see how these changes things, but we're also measuring directly from the patients, what is that? That's why we're doing the gene expression. What is that gene expression in the patient as well? And can we link those two back to each other? We have a lot of data over many years, and Jason, who's been doing this for longer than I have and really set this as a foundation, can highlight that we can really link what's happening in the dish back to the human. He likes to describe it as we have this model of going from bedside to bench and then back again. And so we're able to link these parts back together. We can do that at gene expression level, ultimately going in and looking at a cellular level, either under the microscope, and we have a pathologist who's been working with Courtney to look at biopsies from various different disorders, not this one in particular, but other disorders, to be able to use the technology and the techniques that Courtney's developed to really tease that apart. But that's part of the future work, is to go back to the patient and ask, how can we see what's happening in the dish and link it to what we see and is happening in the patient itself.
Great, thanks. All right, there's one last question. It does overlap a bit with what you were both talking about, Courtney and Weston, a minute ago. But if you want to add on to it, that'd be fine. As you think about caring for children with asthma, how does this study contribute to what we know?
So the care for patients, I guess I'll take that one. It's one of these that we looked at this as a group, where we had these 10 lines when we could see what's happening as a group and see these changes. And we glossed over this, but if you look back at those graphs or imagine them, there's an incredible spread from one individual to the next. And that highlights that there's such a unique individual variation and heterogeneity in both how they're responding to viruses and how they're responding to leptin. And it really, for me, highlights the need to get to know the patient in front of me, what's their history, what's their disease like, and then having known what I know in the lab, think back to, okay, how do we personalize, how do we tailor this, how do we really understand the therapies we're doing in this individual patient in front of us? It's a really exciting opportunity because often in medicine, we have an approach where we do kind of a sledgehammer. We know this works for the bulk of patients, but now we're able to really tease down and get into what's happening at a cellular and molecular level in this patient, and having the tools to do that. And I think that's the future, is being able to really tie the care we're providing to what we understand at an individual level in a patient. Ultimately, it also gets to the idea that every patient is unique. And so we can't just take this approach of saying, oh, it's just leptin. No, it's leptin in some patients, but maybe not others, that may be driving this. And we really need to understand those nuances and differences.
Just one quick comment on that. What Weston is really getting at is that these tools are the key to the future of precision medicine, to really customize therapies to individual patients.
Great. Thanks for that. We did have actually one other question come in that I wanted to ask, and I think that this is likely most relevant for Eka and Brent, but I'll just welcome the panel to answer it if you feel like it's relevant. I think it's probably relevant for both, but perhaps especially so for disparate communities who experience health disparities. Spokane Transit Authority provides excellent transportation to hospitals, including Route 12 Southside Medical Shuttle. I find many professionals are not aware of STA, Spokane Transit Authority bus transportation. Would using a library mobile approach increase research opportunities for your participants?
Yeah, I agree. It's really relevant to our work. And there are examples of people doing that. There, for another study I'm aware of, they do take a bus around and they do Bailey assessments kind of in this little space there. So they go to the communities and to the participants. So it is for sure viable. It's tricky for very dispersed populations because, for example, driving that bus from Okanagan to Walla Walla, you know, for a couple of families in both places would be fairly tricky. But for sure, it's an interesting model that has been tried, and we've thought about that a little bit.
Right. Thanks, everyone. Appreciate the questions and the panel's responses. This wraps up this morning's program. I want to offer a loud virtual round of applause and a sincere thank you to our presenters today. Truly appreciate your time, insight, and the work you're doing for Washington State University, our state, Seattle Children's, and the world. So following today's event, all registered participants are going to receive an email with links to access the session, visit our Wake Up with Research webpage, and find additional contact information for anyone interested in learning more about the research presented today. Once again, just want to say a big thank you to our panelists and to you, our guests, for joining us. We look forward to welcoming you back in 2026 and are highly grateful for your continued support. Have a wonderful day, stay healthy and safe, and go Cougs.